Welcome to the CME accredited podcast series, Rethinking PC-IOLs, From Evidence to Clinical Decisions. I'm your host, Dr. Jennifer Loh, a cataract refractive surgeon in Miami, Florida, and I'll be in conversation with leading clinical experts exploring the presbyopia-correcting intraocular lens landscape, from preoperative diagnostics and surgical planning to patient communication and financial considerations. Hi, welcome back to the fourth episode in our podcast series. This episode is entitled Navigating the Conversation, Setting Expectations for Presbyopic-Correcting IOLs. My name is Dr. Jennifer Loh, and I'm a cataract refractive specialist based out of Miami, Florida. And I'm joined here today by our expert guest, Dr. Caroline Watson, who is also a cataract refractive specialist and a cornea specialist, fellowship trained. Thank you so much for being on our podcast today, Caroline.
Thanks for having me.
Of course. For those of you who were in our session earlier, we talked a lot about the science of selecting the right candidates based on diagnostics and choosing the right IOLs based on formulas and again, all of the data. But now I'd like to pivot a little bit. We touched on this a little bit earlier, but I'd like to really dive into how do we set expectations for advanced technology lenses? How do we navigate the conversation? This is really the art of medicine, right? This is the part where patients really connect with their doctors, and this is our chance to really shine and help them make the right decision. So I do want to mention, we're going to talk about 4 questions. Why communication drives satisfaction and adoption, how to frame spectacle independence versus the possible side effect of halo and glare, how to align lenses with the lifestyle needs, and how to handle financial discussions in a value-based way. So let's start off with the first talking point, Caroline, which is why communication drives satisfaction and adoption. So what do you think, Caroline? What are your best ways to communicate with patients, and how do you understand their visual demands, needs, and lifestyle expectations?
Well, the way that my office does it is we pre-educate patients. So the patients are getting a call prior to their appointment, and we do a very brief kind of introductory call explaining that, hey, this is a very customized appointment. We have technology that's available that you may not be aware of that is potentially able to get you out of glasses. And just so you know, you have XYZ options depending on findings from your testing that we're going to do and the exam Dr. Watson's going to be doing for you. And then she tries to, meet your visual expectations with, whatever decision you make. So it really starts ahead of time. And then as we move through the workup process, my technicians are also revisiting that information. So they're all trained to discuss advanced technology options. And so we're kind of hitting a 1-2 there. And then we get in the room, they meet me, and then we start talking about the different lens technologies based off of what I think would be the best fit for their lifestyle, hobbies, job, visual goals, what their current manifest refraction is. And so there's a lot of variables that come into play with that. And then they get a 4th touch point when they go and meet with my surgery coordinator.
That's awesome. I think that I really love how you and your staff are spending so much time on evaluating and educating them. And I think this is probably the biggest hiccup that we get into when offering these technologies. And I think why a lot of surgeons don't feel comfortable with it. So now, second talking point, you've collected the data, you've examined the patient, you've talked to them about it. How do you explain to them what this multifocal or extended depth of focal focus technology is? How do you explain that it comes with some benefits, there could be some trade-offs? How do you explain that?
I try to keep it as simple as possible, because when you give them too many options, that's when patients get overwhelmed. And so I do it in a very simple way. I don't get in the weeds. I don't go through different multifocal lens platforms. I say, okay, you got 3 options. 1, you can have a laser-assisted cataract surgery. The laser is going to correct your astigmatism. The lens that's going to go inside of your eye when the cataract is removed is a full range lens. So you'll be able to see far away, you'll be able to see to drive, see your television, see your dashboard, see your phone without the use of glasses. However, if you are doing fine needlework, or you're reading a book at night in your bed, or you're at a restaurant in a dimly lit situation, you may need a pair of light readers. But 90% of the time, you will not need glasses on your face. Okay? Second option, laser-assisted cataract surgery. This lens can guarantee distance vision, spectacle independence. We're going to fix your astigmatism with the laser or with a special lens if you need it. And the only thing you're going to need is kind of readers for this arm's length in option. And then you have a basic cataract surgery. Insurance pays for it. It's a lens that's going to correct mostly your distance vision. If you don't opt to correct your astigmatism and you don't opt for a premium lens, you're going to have single distance vision, and you will probably need glasses to fine tune that full range. And that's how I say it. That's it. So, it depends on the patient. If I think they're better equipped to get an EDOF, or if they need a toric, or if I think they're an LAL candidate, then we kind of go in that direction. But that's pretty much my verbiage 80% of the time. And you just want to keep it very straightforward and very specific about what their vision's going to be when they're done. So one, smallest, dependence on glasses, only reading, possibly, occasionally. Second option, you're going to be in readers most of the day. Third option, you're going to be in glasses for that full range, like a progressive lens. And that's pretty much it.
Okay. No, that's a really great summary. And I think that, being confident is really important. You've been through this process before the patients, you've seen the results. Some studies have shown that only 30% of surgeons report being, quote, very confident discussing the trade-offs of the different lenses, and 50% even report no confidence. So I think that, getting comfortable with the lenses is important, and really learning that art of speaking to the patient and discussing it, and a way we frame it, just like you did perfectly. I think I've had experts tell me that there's no such thing as a free lunch in optics, and that there is always some trade-off. This is the way the lenses work. And I think that luckily, though, and I'm sure you'd probably agree, that we're getting newer and newer lens technology all the time. And I think that some of these quote unquote trade-offs have improved. They've improved, maybe not been as bad. But of course, we still have to be cognizant of the issues and explain it to the patient. So perfect. This is something sort of similar to what you just really delved into, but it is topic number 3, which is aligning the lens choice with the lifestyle needs. So again, I know you touched on this a little bit already, but do you have any sort of, I guess, requirements or categorizations where you might say this type of patient should do more of an EDOF lens versus the multifocal? Do you ever discuss custom match, which is, multifocal in one eye and EDOF in another? How do you approach that? And again, you don't have a lot of time with the patient in the exam room, right? It's really just a few minutes, kind of like on this podcast.
So, when I'm doing an exam and we're having this conversation, it takes about 8 minutes for me to really ask those very specific questions and get the data that I need. So I already have an idea of, have they ever used monovision? Have they ever had refractive surgery? Those are like the 2 big things I really want to know. Or have they ever had any kind of retina pathology, retina surgery, eye surgery, whatever, eye trauma? That's all taken and, put in the chart before I even get in the room. I ask every single patient, what do you do for fun? How do you spend your time? How do you spend your day? How do you use your eyes the most? And every patient's going to say something different. And so when they give me an answer, so let's, for example, say I've got a guy who's a former Army Ranger and he likes to shoot guns a lot, or, he likes to go fishing, or he's a pilot, or she sews every day, and, or she gardens, or, there's so many different things that people do. So you really are just taking that into consideration. I live in Alabama, so, people do those things. But you're really just trying to kind of in your mind in that few minutes be like, okay, what's going to be the best option for this person? What's really going to work for this person? And so I do mix and match all the time. I think it's great for certain situations. Monovision's great if they have experience with it. I wouldn't throw monovision on a patient if they haven't ever used it before. Post-refractive, we're talking about LAL to begin with, because that's the easiest way to deal with those. There are some lenses that are very forgiving that you can put in a post-refractive eye. That's a little more advanced, so I don't want to get in the weeds talking about that. But, you really just have to talk to them. You're not just like looking at their eye data. You have to look at the whole person and figure out, okay, what are they doing day to day that is important to them that you can optimize? And then you just make a decision, make a recommendation.
Yeah, I think that's perfect. Spending time with them and getting to know their needs. It's really important, but it's always a tough conversation, right? As we know, there's probably no perfect lens
Right.
yet, but we have a lot of good ones now. Okay, great. So this leads us to really our last topic of conversation, and this tends to be probably one of the most sensitive points for surgeons, and it is typically thought to be the cause of why there's not a lot of surgeon adoption with premium technology. Now, I've heard other statistics. There are some, I think there are some evidence too that the dysphotopsia profile side effects, that's probably the number one reason surgeons are concerned about offering presbyopic lens technology. But, financial discussions and financial concerns is probably a close second, if not a tie, right? I think that as physicians, as surgeons, we're not used to talking to patients about money. It sort of feels a little bit transactional, and we want to respect those boundaries. So, Dr. Watson, give me some tips on how you like to frame the value of the lens and position it in a way so it's not only about the money, but you could still be upfront and honest about the money, right? Like the patients are looking to us to be their guide.
Sure. I do not discuss finances with patients. I allow my surgery counselor to do that. She is very, very well trained. She's done courses. She's done continued education for these things. She's, had multiple industry partners, come in and spend time with her. And, I think the way that she frames it is really showing the value long term for an investment in your vision. And I can totally understand why doctors don't want to discuss money. I don't either. So there are some doctors that do, and they do a great job of doing that, and they feel comfortable with it, but I can totally understand why. I think the mindset that gets in the way is the physician, the surgeon, not thinking that it's a value add for the patient. And if you can change your mindset to really think, hey, this is actually better for these people. We have amazing lens technology. I'm never really worried about nighttime dysphotopsias anymore. Not with the designs that we have now. It's really become a very non-issue for me. And I put these lenses in every week. So it is extremely rare for me to have a patient complain about that. But as far as the money, I would say get your staff in the mindset that this is something that's beneficial for this patient. It's better for their lifestyle. It's better financially for them long term. Even if you do the math 10 years out, it's going to make more sense than continuously purchasing glasses, especially with astigmatism correction built in. Selling astigmatism correction to somebody is probably the easiest way to start. Take a course on how to do manual LRIs. Take a course on how to use a femtosecond laser if you have access to one. Anybody can do a manual LRI. That's easy, and I think the hindrance is mostly because you have to be confident in what you're doing and what you're recommending and not thinking you're taking advantage of a patient. Because I don't think that. I don't think I'm taking advantage of them. I think I'm trying to offer them the best vision possible, to make their lives better. We have so many patients that come in and they hate wearing contacts and they hate wearing glasses and they're very active still, and or they're sitting and working at a computer all day long and they're changing their glasses between looking far away and up close. And I mean, it's a burden sometimes for some people. So it's really trying to make sure they understand that, hey, we can make this better for you. Your vision's going to be awesome. It's an investment in yourself.
Yeah. No, those are all excellent points. And I think what I tell patients is that it's my duty and obligation to tell them about the different options out there. Because I certainly never want someone coming back saying, well, I didn't know, you didn't tell me about these lenses. I think it's their right to know.
Yes.
And we're also not their accountants. Like, we shouldn't make the financial decision for them. We at least, just tell them, hey, it's my job to give you the information. I'm like you, though. I do have a counselor that brings up the cost. I agree. I don't want to start talking dollars and cents, specifically to the patient. Of course, if they ask me if it's out of pocket and why it is, I'm happy to explain those things. But I do like to separate the exact precise dollar amount money conversation. I think it's good for them to hear that from someone else. And then, basically again, I'm happy to answer questions if the patient has more questions, but I do like that to be brought up separately. And I really focus more on the medical side of things. But I think that it's something we actually, we can't ignore. We have to tell them about lenses.
Yeah. Agreed.
And we let them decide if it's a value add for them. But I also think, like you said, it's not, I don't think it's a luxury. It's actually a hindrance and a downside to not be able to see, things up close, like your food, your watch, being in the shower, being able to see the shampoo bottle. Like, I frame it like that, where it's not a luxury. It's about getting through the basic functions of life. So,
well, just one more thing I wanted to add. You never know who prioritizes what. You cannot assume that someone is not able or won't invest in this type of technology for themselves, because you're going to be wrong and you're going to miss an opportunity to help someone. So it's really changing that mindset of everyone's a candidate until they're not. Everyone's a candidate until they give you a reason for them to not be. And so it's just, you can't assume that people don't want the best vision for themselves, especially, when they're still very active and they're with it and they think it's cool and fun. So
yeah. No, I agree. It's our duty to tell them about all the options. Just like we still tell them about the monofocal option, we should still tell them about the advanced technology options, because I think it's in their right to know now.
it is.
Okay, well, perfect. Thank you. Well, this really nicely, ends our podcast. I wanted to thank you again, Dr. Watson, for joining us, spending your time. It's been a great series. We're helping, surgeons understand how to help their patients achieve the desired vision after cataract surgery. It's more than just about technology. It's also about understanding our patients' needs and customizing the available options to them. So I really appreciate you speaking to us, and I want to thank the audience again for your time. And also, please feel free to listen to the other podcasts in our series. You can explore all episodes in this series, along with additional activities in the full CME accredited program. If you're listening outside the program website, the link is in the show notes.